Well, good afternoon, everyone. Glad that you could join us for the VPS Research Spotlight here, August the 16th. Today, we have, I think, a very interesting publication and discussion. It's going to be presented by Dr. Julia Heneghan, who's currently an assistant professor at the University of Minnesota in the Department of Critical Care. A quick rundown, I think Julia received her MD at Brown University and her master's at George Washington School of Medicine. She did her internship and residency at Rainbow Babies, Case Western. And then she did her critical care fellowship at Children's Medical Center in DC. And she's got a particular interest in post-intensive care syndrome in children with medical complexity, and has a couple of grants that she's focusing on that patient population. So I think we have a good opportunity here to see some of her recent interest in action, and also get an opportunity at the end of her presentation to maybe ask her a few questions and what kind of problems she's run into and where she's heading with some of this. Today, she's actually going to be talking about her publication that was in Pediatric Critical Care Medicine this past January, which was on the variable identification of children with medical complexity in the United States pediatric ICUs. So, not taking up any more of her time, welcome, Julia. We're looking forward to your discussion today.
Great. Thank you, Dr. Rice, for the introduction. I'm just going to go ahead and share my presentation. So again, thank you for the opportunity to present. As Dr. Rice mentioned, I'm going to talk about a recent publication in Pediatric Critical Care Medicine that used VPS data to identify children with medical complexities in United States PICUs. So I have no relevant financial disclosures, but like I said, the data for this publication were provided by VPS. I have two study co-authors for this project, both of whom are at Lurie Children's Hospital in Chicago. Sriram Rangapal is an emergency physician who has similar interests in the care of children with medical complexity. And I think many of you also know Denise Goodman, who's in critical care at Lurie and has a long history of research and policy work related to this patient population. So I'm going to start with something a little different. Given that it's the middle of the summer, I thought I would remind you all of bronchiolitis. And I would ask all of you to think about the patient that comes to mind when I say the word bronchiolitis. So if you're in the medical education sphere, this is something along the lines of, I'm asking you to give me an illness script for bronchiolitis. Think about that patient. And my guess is that most of you, as you think about a patient with bronchiolitis, come up with something that looks like this, right? A relatively young child, potentially intubated for them to be in our unit. And you have a whole bunch of other factors that have come to mind. You know, frequently associated with RSV, gets better before it gets worse, things like that. But I think that if I asked you to have that same thought process of imagine patients who are medically complex, there would be a whole lot more variability if we went around and kind of surveyed everyone who's listening to this talk about the mental image that came to mind, what their mental model of a child who's medically complex is, compared to the mental models that you all just had of patients with bronchiolitis. And so, you know, the pictures may look something like this, but they may not. It may have been a child who you've admitted 6 times for diabetes and DKA. It may be a child who's never left the hospital. And I would imagine that that range is quite a bit larger than the patients with bronchiolitis. So that really leads kind of to, and if you know what this is the Supreme Court of the United States in Washington, D.C. And in 1964, Justice Potter Stewart wrote a concurring opinion in the case Jacob Ellis versus Ohio, which is really probably irrelevant to most of you. Except this is where the framework of I know it when I see it came from. And I think that that's really the approach that many of us as clinicians take when it comes to children with medical complexity. We may or may not be able to actually articulate what medical complexity is, but when a patient comes into our unit who is medically complex, we know it when we see it. So this, I'm going to shift a little bit because I think that's what we do clinically, but that doesn't work from a research standpoint. And so there's a framework that one of my colleagues here in Minnesota, Miriam Shapiro, published in 2017, which is really a framework for thinking about different levels of medical complexity. And so this figure is adapted from her paper. The first outer thing is in the red is children and youth with special healthcare needs. And so this is actually a definition from the Maternal and Child Health Bureau that is an intentionally broad definition. So children and youth with special healthcare needs have or are at risk for chronic physical, developmental, behavioral, or emotional conditions. And then that smaller subgroup in the yellow circle is this idea of children with medical complexity. And the thought here is that those children have multiple or significant health problems, usually with high healthcare needs and utilization, and some of them may be dependent on various forms of medical technology. So we know, using this sort of framework, that children with medical complexity are increasing in number over time. They're more likely to experience critical illness, especially repeated critical illness, and be in our units over and over again. Some of them may even be in our units over and over again if they aren't critically ill, but because there's nowhere else in the hospital that's able to care for them, thinking specifically about patients with tracheostomies and other sorts of technology dependence. And relatedly, they're more likely to have increased ICU and hospital resource utilization. And thinking back to that framework, the patients who we see in our ICU and what Miriam describes in her paper is this concept of children with complex chronic critical illness. Where really you are dependent on ICU level care. And these are all great frameworks to start from, but they really lead into some limitations in research. So any sort of, I talked a little bit about, we have this clinical gestalt about what a child with medical complexity is, but in order to be able to do high quality research on this patient population, we really need to move away from a gestalt question and be able to use things like administrative data that are available through VPS and other databases to query who are these patients and why are they coming to our units. So we have difficulty in research in children with medical complexity because that patient population is heterogeneous, because that mental model that you did for me at the beginning of the talk is so broad. It's also difficult to know how accurate some of our administrative data is. Not the question of, is the data that we're extracting accurate, but how accurate is that data in actually identifying patients? So is the coding correct and fully encapsulating the experience that patients and families are having? Does the system that we're using to define medical complexity change as things like ICD codes are updated and modified over time? Are we accurately capturing the time of onset for diagnoses, or are they kind of reported just episodically? And then are those diagnosis codes and procedural codes that we use really fully representative of what we think they are? We also know, like I said, that this patient group is changing over time, particularly as many patients are graduating from the NICU world with increased amounts of technology dependence and then coming to the pediatric ICU for ongoing care. And then we also know, like I referred to before, that there's a lot of variability in clinical practice where these children are cared for if in the hospital, whether it's for true severity of illness reasons or hospital policy reasons, and how you tease that out. So two of the most common definitions that are used for medical complexity to move away from that gestalt basis to let's actually define things, you've probably heard of. So they're the pediatric complex chronic conditions, or CCCs, also sometimes known as the Feutner definition. Chris Feutner is the physician at CHOP who started this process. And then the pediatric medical complexity algorithm, which came from Rita Mangione-Smith and others in the Seattle area. So both of these definitions are used in the research world to try to identify and define medical complexity. Interestingly, neither one of them were designed for that particular purpose. The Fuchner definition was originally, way back in the day, designed to identify patients who would potentially need palliative care or hospice in the future. And then the PMCA was designed to be kind of this longitudinal definition of hospital encounters. Both of them are now based on ICD-10 codes that have been updated over time as those have changed. For CCC, there are 10 mutually exclusive diagnosis categories, whereas PMCA has 18 mutually exclusive diagnosis categories. Specifically, PMCA includes some behavioral and psychiatric diagnoses that are not included in CCC. And then the CCCs have specific flags for children with technology dependence or who have had a transplant of some sort, whereas PMCA divides all of the children into one of three groups. So either based on the set of diagnosis codes you have, the patient can be classified as having no chronic disease, non-complex chronic disease, or complex chronic disease. And complex chronic disease, which is kind of my area of interest, as Dr. Rice alluded to, you have to have at least 2 chronic conditions or a malignancy or a progressive condition. So something like spinal muscular atrophy would be kind of included in this as a progressive condition. So we think when we approach these definitions that these definitions are just different ways of saying the same thing, just like this word cloud is all different ways of saying hello. But we don't know if these different definitions are actually different ways of saying different things. So in this word cloud, it's not just hello, but some of these also say goodbye in different languages. And so that's really what prompted my interest in this study, is figuring out to what extent do those different definitions, the PMCA and CCC of medical complexity, overlap in their identification of patients, and then doing some additional work to try to better describe demographic and clinical characteristics of children with medical complexities who come into our PICUs. Some of that work has been done before by Jeff Edwards and Titus Chan, and I'll show some comparative data, but those are several years kind of more historical than the data that we were able to get through VPS. So we included 131 VPS institutions in the United States and looked at index admissions, so first admission of patients under the age of 21 between 2017 and 2019. As many of you may know, VPS doesn't always collect ICD codes, so we crosswalked STAR codes, which is how VPS characterizes diagnoses, to their relevant ICD codes. And then we were interested specifically in multi-system complexity. So that PMCA, complex chronic disease flag, like I was talking about, or at least 2 CCCs from the Fuchner definitions. And really, we were interested, like I said, in the overlap of those definitions. And during this period, there were about 300,000 index PICU encounters in the participating sites, and about 70% of them met at least one of the definitions. And what you can see here is that there was the circle with the solid line represents those patients that were identified by the PMCA definition, whereas the circle with the dashed outline represents patients who are identified by CCC, and then you have the area in the middle of the overlap. We used a statistical test called Cohen's kappa, and this showed that there was really only moderate agreement between the 2 definitions. So we then said, okay, so if we're going to look at patients who are only identified by CCC, what are their characteristics? Well, they were younger, they were more likely to be unscheduled admissions, they were more likely to have respiratory illness, and they had higher mortality compared to patients who are identified only by PMCA, who are older, tended to be scheduled admissions, and discharged home directly from the ICU after shorter lengths of stay. If you are identified by both CCC and PMCA, those were actually the sickest patients. They had higher levels of therapeutic interventions, longer lengths of stay, and then they were more likely to come back to the ICU on subsequent hospital encounters. So why is this sort of difference in what we're identifying with one definition compared to a different definition important? Well, there's a lot of research studies out there that try to control for the presence of medical complexity by saying either you have CCC or you don't have CCC, but they're not actually capturing the fact that these patient populations are potentially different, and therefore you're not controlling for what you think you're controlling. So it's really kind of that second word cloud where we're potentially identifying different ways of talking about different patient populations. So the next thing that we did was to look and say, okay, we're going to keep the definition of medical complexity by PMCA constant across the study population, and we're going to adjust the number of complex chronic conditions that it takes to kind of qualify to have medical complexity. And you can see in panel A here, this represents when you only needed a single CCC diagnosis to count. And that's actually where the highest kappa or the highest agreement occurred. But isn't theoretically consistent with the multi-system complexity. This in panel B you've seen before. This is the first image that I showed. Panel C is 3 definitions, and panel D is 4 CCC diagnoses to meet that. And you can see that you've basically entirely contained the definition within another. So it looks a lot like that first framework from the Shapiro paper that I talked about. But this has the lowest kappa, the least amount of agreement between the definitions. We then looked, I've alluded to these already, but this is some of the specific demographic and clinical characteristics across the groups that were identified just by CCC, just by PMCA, and then the overlap group in the middle. So we looked in the manuscript at patient characteristics, their primary diagnosis categories, things that had to do with their admission, so were they scheduled or admitted from the procedural area, what their median PRISM scores were, how many of them had tracheostomies, and then we also looked at procedural exposure during their ICU encounters, as well as outcomes, both during that ICU hospitalization, as well as where they were discharged to, and how many of them came back to the ICU following the year of discharge. And then, like I said, there's a lot of challenges in doing this, and one of the potential challenges is how does this compare to prior studies? And so, as I alluded to, Jeff Edwards had done a prior study using VPS data in 2008, and they used the ICD-9 version of CCC and did a modified version, and they showed a relatively lower proportion of ICU admissions meeting medical complexity characteristics. They showed slightly different patterns in primary diagnosis. About twice as many of their patients were post-procedural, and they had about the same ICU length of stay. Our manuscript described that procedural exposure, which wasn't described in the Edwards paper. And then similarly, Titus Chan used the FIS database in 2012 and 2013 to use the ICD-9 version of PMCA, whereas we used the ICD-10 version. And again, you see a higher proportion of ICU admissions, potentially different age distributions. We had about half the mortality rate compared to what was described previously. Again, different patterns of primary diagnoses, a shorter ICU length of stay, and less ICU procedural exposure in our patient cohort. And so I think, again, this just alludes back to really trying to make sure that we're using the definitions to be the different ways of saying the same thing instead of different ways of saying different things. So I'm happy to take any questions or feedback, and my email address is here. I'm happy to talk to people who are interested in this sort of topic and research and care of this patient population. Thank you.
Thank you, Julia. Very interesting. Not sure I see any questions coming in yet. While we're waiting here, I think we have a few moments that we can have some questions, but I was going to ask you, I saw in your discussion, you were mentioning about the difficulty that using the VPS data, which we use the star codes, which is basically a lumping, if you will, of various ICD-10s that are similar in nature, only because that makes it easier to sort and pull data for researchers, which is why it came about back in the early days of VPS. But you mentioned that that creating that crosswalk caused difficulties for you in terms of determining your study or doing your study. Can you explain a little bit more about that? What problems that posed for you?
Sure. Shout out to Jamie Palumbo for putting the crosswalk together for us and getting it to us. It was very helpful to do it, but it wasn't necessarily that it caused problems, but both PMCA and CCC are based on ICD codes, and that's how they've been developed and validated. And so when you're approaching a database that doesn't use ICD codes as their primary mechanism of including patient diagnoses, there's the potential that you are not capturing the patients in the ways that the definition is intended to be used. So obviously there are some VPS sites and encounters that have ICD codes associated with them. So we could have done a sub-analysis and looked just at the patients for whom ICD codes are available. But it is a limitation of using ICD-based definitions in a database that doesn't primarily use them. And so this would apply to any sort of definition. So thinking about, diagnosing or identifying patients with septic shock on the basis of ICD codes, you would have to kind of reinvent that diagnostic process to use star codes in VPS.
Right.
Does that answer your question?
Yep, I think it does. So I was just going to say, not all of the units, well, all the units have to use star codes because that's our minimum, but there's quite a few number of the units that actually use ICD-10s and enter those. So I think the sub-analysis might have made that part easier without having to do the crosswalk. So
yes, and I think it was more, I think the intention in the discussion was more just to say, if you as a researcher are interested in applying these definitions to a database like VPS where it's not universal, you're going to be limited in kind of either choosing to do a sub-analysis or saying we're going to crosswalk, knowing that there's potential fuzziness in the definition that way.
Right. Okay. Looks like there's one question here. Let me see if I can bring it up. Okay. This is coming from Dr. Forbes over in Akron, and Michael is asking, he says, first provocative presentation. Seems some differences between the methods and scoring is the purpose behind the method. If the goal of identifying patients with CCC is to control the cost curve, the components are different if we are interested in optimizing outcomes for those with CCC. Has your team considered comparing costs between the definitions?
Sure, and that's something that we have done using FIS. As you are probably aware, VPS does not have costs data directly associated with it. And it is, we have seen differences in costs, and I'm happy to share that reference if that would be of interest to you. I think, what is perhaps more provocative about this is that yes, these definitions were originally designed to be used in different ways, but when we in the research community have applied them for research purposes, we use them interchangeably. And so we just say patients with medical complexity, and a lot of times, unless you know about kind of the difference between definition A and definition B, people just allied over that, and they assume that we're talking about the same thing, about the same group of patients being identified, whether you're using method A or method B. And that was something that was really striking to me in talking to researchers, and was part of my reason for approaching VPS to do this study, was to say, can we actually prove or disprove how similar these patient populations are?
Very good. Oh, looks like there's another question. Sorry, I'm not too facile with this.
That's
This
okay.
one-
I see it in the chat, so I can answer it.
Okay, got it. I'm sorry.
No,
Good. I'm
that's
glad.
fine. I figured out how to pull it up. So Gerardo Sotos Campos, who I believe is at VPS, is asking about the higher mortality in Titus Chan's article, which used the FIS database versus VPS. And he is wondering about if they looked at only critically ill children or all pediatric patients, which is a great question, because FIS does include all patients, as opposed to being an ICU specific database like VPS is. And the mortality data that I pulled in, and the Chan study in general, looked at just critically ill pediatric encounters. So it should be a relatively similar patient population.
And I have another question, Julia. You had mentioned, I guess the question that I have really is there a difference if these are new diagnoses versus older diagnoses in terms of the definition for chronic complexity? And if so, with the VPS, there is a function that carries diagnoses forward over a period of time. So resolution is in there, but also the potential for when it was first entered. So I just was questioning whether that was of value or not.
Yes, so it is of value. So this gets a little into the weeds of how each of these definitions has historically been operationalized and validated. So in general, when CCC is, so the Feutner definition is used for research, it's done without a look back. So it's done just on the encounter that we are studying. So if you have any of those diagnoses during that encounter, you would get what is called a flag. That is in contrast to PMCA, which was developed and validated using look back data. So the PMCA originally was validated using 3 years of data from the encounter and looking back 3 years, and using all of the diagnosis codes that were recorded during that time period. So that's the initial development and validation. In other studies that our group has done using FIS, we have shortened that look back period to 1 year, as well as the specific encounter that we're looking at. And you really don't see a substantive change in the ability to identify PMCA categories consistently, whether your look back is non-existent, so just that one encounter, or a shorter look back, or the originally validated 3-year look back. So for this particular study, we didn't use those flags in VPS that really help assess whether this is a new diagnosis or a more chronic diagnosis, but certainly is an area of interest for us and something that we're looking to explore further.
Very good. Well, what's your next plan here? It looks like you got several things up in the air when I looked at your CV.
Sure. So one of the things that I'm really interested in is right now, when we think about children with medical complexity, the PMCA and CCC, are, like I said, are the two biggest diagnoses, are the two biggest definitions, and both of those, as we've talked about, are diagnosis based. I'm actually interested in moving away from a diagnosis basis of defining children with medical complexity to a more prognosis basis. Because I think that would allow us to better do things like risk stratify or control or do other things for research purposes, and actually have these sorts of things be meaningful. So I'm working on some prospective studies related to that question, and then I'm additionally looking at some VPS data about functional status changes in children over time, specifically in children. So we're going to look at all comers, but as you can probably tell from this presentation, I have a specific interest in children with complex medical conditions. So trying to look and see how an episode of critical illness is related to changes in a patient's functional status.
That's terrific. And I'm very happy that you were able to find time in your schedule to be able to spend time with us here at VPS and doing the Spotlight Research Program today. And hopefully some of the participants will have questions for you. And I see you're giving them your email address. So again, thank you so much for the presentation. It was very nice, and really appreciate your publication work in this area.
Well, great. I appreciate VPS's support both in the invitation to speak today, but then also in the provision of data and producing high quality research. So thank you.
We look forward to hearing more from you in the future.
Thank you.